Dr. Jeff talks love. Dr. Jeff talks life. Answers your questions, cuts through the strife. Sex and intimacy, real and true. Evidence-based, made just for you.
Hello, welcome to Dr. Jeff Talks About Sex and Intimacy, the podcast where we have honest, evidence-based conversations about sexual health, intimacy, and the parts of the human experience that are too often wrapped in silence and shame. We bring them all forward in this podcast. I'm your host, Dr. Jeff Albaugh. Today, you are joining us for episode 52. Pretty exciting. A full year's worth of Dr. Jeff Talks About Sex and Intimacy. This one is on restoring length, curvature, and hope, a conversation with Dr. Landon Trost. Whether you're watching live or listening to the recording, I just want to take a minute to say thank you. Thank you so much. I truly, truly appreciate each and every one of you. You are the only reason that this podcast exists, and your engagement, your curiosity, your willingness to learn are really what makes it all possible. So thanks for being here. Just to let you know again, we are connected across all those social media platforms: Facebook, YouTube, X, LinkedIn. If you're joining on X and you have a question, just hop over to YouTube, LinkedIn, Facebook, StreamYard, so you can actually interact with us and ask your question. Quick favor, if you are on Facebook, please follow us. The more people that follow us on Facebook, the more we can do on Facebook. So please follow us if you're a Facebook person. And if you're a follower, thank you. So also, please visit the website. The website to learn more about all the amazing podcasts that we've had. You can watch 52 different podcasts you can watch from the website. You can pull up the calendar on the website and see what's coming up and all the amazing people we have all the way through March. We've already got people programmed in. So exciting, great stuff on the website. Go to it and find out what's new. Also, you can take us with you, whether you're in the car, wherever you go, we go there with you. If you're working out, we'll work out with you. Dr. Jeff Talks About Sex and Intimacy will be there. If you're on that road trip, take us along. You can learn a few things about sex and intimacy as you explore the road, and wherever you're going, we're there with you. As always, I would like to take a moment to just welcome everyone and let you know that whatever your sexual orientation, whatever your gender identity or your relationship style, know that you are very welcome here in this space to learn. We're so glad you're here, and you are most welcome. The mission of the podcast is really simple if you haven't been here before. It's to empower and enlighten you with the evidence-based, that's the science-based information that improves your sexual health and deepens your amazing relationships so you can live this one miraculous, wholehearted life with more love. Who doesn't want more of that? Today's episode tackles a topic for many men that quietly struggle with this issue and often struggle alone. Changes in penile length, shape, even penile curvature. Whether after prostate cancer treatment, after an injury, Peyronie's disease, or other medical conditions, these physical changes can deeply affect a man's sense of how they feel, their identity, their confidence, and their intimate connection. Yet, they're rarely talked about. That's why we always bring these topics, and that's why we're here tonight talking about it. So the good news is there are effective science-based ways to restore function, address curvature, and just as importantly, to restore your hope. Hope is so powerful and so important. I'm honored to be joined by one of the world's leading experts in this area, my colleague, Dr. Landon Trost, and he is a board-certified urologist. He's an internationally recognized expert in men's sexual health, in Peyronie's disease, penile rehabilitation, and advanced restorative therapies. He serves as the founder and medical director of the Male Fertility and Peyronie's Clinic at the Utah Men's Health Center, and he has dedicated his career to helping men recover sexual function and quality of life after injury, illness, or cancer treatment. Dr. Trost has authored many peer-reviewed publications and book chapters and is frequently invited to speak nationally and internationally on penile curvature, length restoration, traction therapy, and emerging technologies in sexual medicine. Known for his data-driven, that science-based yet deeply patient-centered approach, Dr. Trost is passionate about dispelling misinformation, setting realistic expectations, and helping men regain both physical function and confidence. He's going to talk to us tonight also about the device that he invented that we use in our clinic and people use all over the world. It's an amazing device. I am so honored to have him here. He is a sexual medicine colleague of mine from the Sexual Medicine Society of North America. Welcome, Dr. Landon Trost.
Well, thank you, Jeff, for having me. It's good to be with you, and I appreciate the invitation.
Oh, so great to have you. We're excited to hear what you have to say. And without further ado, I'm going to hand it over.
All right, that sounds good. Well, and again, appreciate the topic, and I think your introductory comments are spot on. This is one of the areas where the psychological component ends up being, arguably much worse than the actual physical deformity is, and we'll get into that a little bit. So, like you mentioned, the topic is going to be restoring length, curvature, and hope. Um, and to start off, it's always good to go through disclosures because you always want to know what's the person's bias. Whoever's speaking, where are they coming from background wise. So as you mentioned, I did invent RestoreX, RestoreXL, and I'm a part owner of Pathright Medical. So you want to keep that in mind. There's always going to be a bias when you invent something because you clearly believe in it because you invented it. So just kind of keep that in mind. That said, I did put the ownership shares in a blind trust to try to distance myself as much as possible because as Jeff knows, I mean, I've worked my hardest to stay completely unbiased the best I could and not taking money from industry or anything along those lines. The president-elect of SMSNA and editor of the Journal of Sexual Medicine, but I don't speak on behalf of either of those. So tonight's lecture is going to be, my lecture, my opinions type thing. And I also received grants from Endo Pharmaceuticals for research, but these were studies that we initiated. So it wasn't something Endo asked us to do. And so I never took any PI money or the primary investigator funds that come with it. So, and again, I'm not speaking on behalf of any of those entities. Well, if you've been to the Louvre in Paris, well, and I guess they rotate, exhibits and things like that. But this was there about a year and a half ago or so, and I'm definitely not an art historian, so someone who's listening is going to say that I'm completely butchering the entire purpose of this. But I found this one interesting. So this is four adult men all looking down at their penis, and you can see all of them have the same curvature to the penis. So I zoomed in on it on the left here. And my wife at the time said, "You're a weirdo," and walked away. But at least look at the person across. At least there's one other weirdo with a phone out, taking pictures of this too. But so I found this was real intriguing because it exemplifies, several things. And one is men just care about the penis, and it, whether or not it's impacting partnership and things like that, it does have an impact on them. Peyronie's disease is the name of the condition most often associated with penile deformities, meaning acquired deformities, ones you weren't born with. It goes all the way back to 3000 BC. You can see a picture on the right there was taken from a statue that was in this healing deity temple. And the concept was you'd build a statue of yourself that exhibited your disease state, you throw it in the temple, and then that would help cure it. And the only thing wrong with this particular statue was the bent penis. And so they think that it indeed was the first known potential case of Peyronie's disease. And then there's the physician on the left there is François Gigot de la Peyronie. He's the one who essentially it was named after, even though it was recorded before then. Well, curvature itself clearly, oh, and I should give you a warning. There's going to be a couple penis pictures in this one. So if you don't want to see penis pictures, probably, may want to turn off the screen right now. But curve clearly impacts function. You look at the example on the left, and anytime you're about 30 degrees or more on a side curve, that tends to be where people will start to complain, more around the 50, 60 degree for up or down curves. But also you can get things like buckling, areas where it's going to narrow significantly, loss of erectile function, either in front of or behind a curvature, like you see the example on the right there. You can imagine how much more instability that causes when you get that kind of narrowing. And then, of course, in many cases, it makes it much harder to achieve and maintain an erection, which sometimes even gets worse after you treat it. So all of these things will clearly impact, function itself. But interestingly, even if you jump into cases like after having your prostate removed, so post-prostatectomy, one of the biggest complaints ends up being either erectile function or loss of length. Even after the cancer's gone, all of these things, what people are really complaining about is either urinary symptoms or sexual function symptoms. This was a study done a little over 10 years ago now, where they looked at men post prostatectomy, a little over 1,000 men, and compared it to men who hadn't had a prostatectomy. And more than half reported loss of length versus about a quarter of men who were just getting older. And that's interesting in and of itself. As men get older, some of them start to complain about loss of length. And some people think, well, maybe it's not being used as much. That may be the reason. We just don't know. But we do know there's several other conditions that matter for length. So diabetes, Peyronie's, surgery like a prostatectomy or other surgeries. And then some men are just born with a much, much smaller penis compared to average. And all of that impacts not only the function, like we talked about, but it can impact confidence, urinary hygiene in some cases when it gets to be real severe. So there's other aspects to it as well. And like we're touching on lightly here, it goes well beyond just the functional side of it. So when you look at the psychological numbers, now we never published this, just we had a huge survey with a lot of data, and Matt Siegelman was our resident at the time. And whenever you're publishing these things, you just don't, you have so much data you can't publish it all. But interestingly, of this study of men up to 30 years after their disease onset, on average, they were rating their negative impact on their relationship 7 out of 10. So 10 being the highest for it. This is many years after the fact. You'd think a lot of this would have resolved and things like that, but it just shows that whether or not it is truly impacting it psychologically uh, on the person who's affected with the disease side, it clearly is having a major impact. Negative impact on self-esteem, 54%, worsened self-image, 50%. So it's wrong to write this off as a condition that doesn't have a major impact on the psychological side of things. The other thing too is whenever you get relationship type factors, it can also impact the person emotionally. So you're looking 81% of men with Peyronie's will report emotional distress. Main predictors are loss of length and relationship issues. Relationship itself, 54%, and it predicts emotional problems, kind of back and forth. And then the extent of curve directly relates to the amount of bother. And interestingly, 3/4 of men will have negative psychological effects from this, and up to 48% will say they have depression due to the curvature alone, which is crazy. I mean, some people will have, I mean, the only thing that comes relatively close to this is things like heart attacks and other things like that. But this has a major, major impact on depression and other symptoms. So now, whenever you get those types of symptoms, it starts to affect other aspects of sexual function. They're all interrelated. So you get curvature, you get depression, you get relationship issues. Now that starts to feed into libido because as you get depression, libido goes down, and now there's not that underlying drive that further exacerbates any problems with the relationship. It leads to anxiety, stress, and things like that. So OR here means odds ratio. So it's roughly a threefold higher rate of emotional problems when you have something like depression and, or I'm sorry, when you have like low libido and depression, it's 2 to 3-fold higher rates of it. So you can see compared to even alcohol, pain disorders, medication related, depression ends up being a primary driver of decreased libido and what can lead to depression on the things like penile length loss and penile curvature. So major impacts here. Now, this is one of my favorite slides of any of the talks and different things. If you ask, and these are hard studies to do, I'm real interested in whenever one of these is published, but if you ask people, what are you willing to give up, A or B? Would you rather have 3 extra months of life or this? And I mean, my kids do this all the time. Would you rather, and that's kind of what this study was. And what they found was, as far as severe erectile dysfunction, people would give up 4 months of life to not have severe erectile dysfunction. Interestingly, they'd give 5 months of life to not have severe libido related issues. They want that drive back. They want to feel like themselves. Now you compare that to other things, severe urinary leakage, people would give up over 2 years of life to not have that problem. So you get an idea of what people are willing to do trade-off wise there. Okay, so the good news is there are treatments out there, and really, honestly, it's never been a better time to have curvature if you had to pick a time in the world thus far. Because as Jeff well knows, Peyronie's disease is it's a graveyard of bad therapies. You go from Pentox, vitamin E topicals, Reddit, and mercurial rubs and things like that. These history of PD therapies have been around forever, and they just don't work. Well, I'm going to talk about three. This first one's penile traction. This was released about a decade ago now. It's called RestoreX. It's basically a clamp that grabs the head of the penis and then stretches it. It provides enough stretch and it gives you an indicator when you're not doing enough stretch where you can dynamically adjust it and lengthen it. And so it'll show it being adjusted and lengthened here. It was developed at Mayo Clinic during my time there, and hence the little Mayo moniker there. It allows you to counterbend as well. So in the case of curvature, so that you can bend against curves, and then it's good for lengthening. The other treatment I'm going to talk on lightly is XIAFLEX. It's basically an injection that you put into the scar of the penis, and then you inject the medicine, and it dissolves the scar. And then finally, the other one we'll just real lightly talk on because of side effects is going to be surgery, which is basically where you put stitches in to straighten things. Or on the right, you can see you put a graft into the gap that existed where the curve and narrowing was. Now, high level, if you said, what are your big take homes in one slide? It's this one. And that is of the effective treatments out there. And here we're talking specifically of guys who have intact erectile function. So this isn't guys with severe erectile dysfunction. Those guys would best be treated with an implant. But if you have good erectile function, then you're looking at either surgery, like I just showed, XIAFLEX, RestoreX, or the combination of the two. Now, the great thing about surgery is it for sure corrects curve. But the downside is you lose length, lose more than any of the other therapies, and you have notable side effects that I'll show in a second. XIAFLEX, you lose a teeny bit of length. You do improve your curvature, and you do have some bruising and bleeding side effects there. RestoreX, no real side effects, but it's not as effective alone at treating curvature. It's probably your best one of these therapies for sure at improving length, but for curve, it's not quite as good. But really, kind of the mainstay in 2025, 2026 is the combination of XIAFLEX and RestoreX. That tends to give you the best overall profile, even though you'll always have side effects. When you compare it against the alternatives, it's probably our best treatment so far. Now, we did a study, it's still ongoing, where we randomized guys into getting either surgery for curvature or XIAFLEX and RestoreX. So surgery and RestoreX or XIAFLEX and RestoreX. And surprisingly, XIAFLEX and RestoreX did better in just about every way we measured it. If you could do it again, what would you pick? So of the guys who were initially XIAFLEX, all of them said either traction or XIAFLEX. Of those who were originally surgery, the far majority said XIAFLEX, and then only a small percentage still said surgery, even after having it done. So the majority of men lean that direction. Before you entered the study, what would you have picked? The far majority, again, were XIAFLEX. And I should say, so XIAFLEX here includes traction. This one's just traction alone. So when you look at the results of it, so there's not enough time in the podcast to go into this in detail. We literally could spend hours and hours talking about this in many different boring ways. But as time's gone on, we've gotten better and better at administering XIAFLEX. Orange is the one that you want to follow, and basically these are the different changes we've made to techniques over time. Now, the effect of the change usually is about a year to 2 years later because the data takes about 9 months to finish a treatment before it'll pour in. So you can see after we started implementing RestoreX, we did see a big jump in the orange line here. And then all these other changes that have made a difference slowly kind of improve things as well. We more recently started incorporating this aggressive modeling. We saw another jump after that. But there's lots of little things that have led to greater improvement. So there's just not enough time to go into these in detail now. Now, when you look at the combination of XIAFLEX and RestoreX, what can you expect? And this was early on, so this is years before. So you look 2019, we're basically sitting right here. This is right after we started doing the RestoreX plus XIAFLEX. Since then, of course, we've gotten greater improvements, but you're looking roughly 35-degree improvement, or around 55-ish% improvement there. And when you look at length, so XIAFLEX plus RestoreX, you do gain length. If you do XIAFLEX alone or XIAFLEX and other traction devices, it just doesn't work as well. So this is what originally led kind of that change in technique, one of the early studies we had for it. Since then, we've adopted what we call a salvage protocol, which is basically you start with a couple therapies. If they're not good enough, you get more aggressive as time goes on. And this has been dramatic. So our most recent data is we're looking about a median 86% curve improvement without surgery. And when you ask patients, because they're the better, more predictable answer on things, because they're always going to tell you the truth on it versus, this may be our measurement, but to show and see if we have any bias, when you ask patients themselves, they're reporting a 90% median improvement in outcomes, and none of them are saying their curve is worse or even neutral in this case. Overall satisfaction, very satisfied, somewhat satisfied. How symptoms are now, still there, but mild compared to what they were pre. Now, anytime you're in a study, you're always going to have some bias because people like to feel like they went into something that they did something that was right. So reality tends to be a little worse than the studies in many cases, but still overall, these data are looking good. Just two final comments here, two final slides. This concept of psychotherapy, beyond just like the traditional term and definition of psychotherapy, is sometimes therapies have a psychological benefit. Now, anytime you have a successful outcome, that doesn't always guarantee that you're going to have satisfaction. But interestingly, even if you look at dissatisfied patients, the majority still would recommend different procedures to others. Now, these are coming from multiple different types of therapy, but it just highlights overall that the conditions sometimes are bad enough that even if you do have bad side effects from something, you're still glad that you did it compared to if you hadn't. Multiple studies have showed improved overall couple relationships. When you look at cosmetic type surgeries, you're looking at improved body image, self-esteem, quality of life, and anxiety. So it goes beyond function with many of these types of things. And really, a lot of patients will judge satisfaction by how much it improves self-esteem, kind of indirectly or subconsciously. So a key point here is therapies impact not only the function themselves, which is important and it's an aspect of it, but the psychological aspects as well. So in summary, there's several penile conditions that can lead to penile deformities and length loss. Penile deformity itself can lead to functional and psychological impacts. There are effective therapies in 2025, 2026 that have fewer long-term side effects compared to historical options. And this overall offers much needed hope to men who are struggling with these traditionally very difficult to treat conditions overall. With that, I thank you very much for your time and look forward to the discussion.
Awesome. Well, you did exactly what I knew you would do. You offered great hope with these, and also scientific evidence to support what really works and what is the best thing for patients. So really appreciate it. Great presentation. Really appreciate
Oh, my
it.
pleasure. Yeah.
So, I was thinking a lot about, I love that you throw in the psychological component, and we did actually with SMSNA. I really applauded them. We did a segment talking about the psychological impacts of Peyronie's disease with a psychologist and myself. I'm a sexuality counselor as well as advanced practice urology clinical nurse specialist. So I think it's so important to remember that piece of it and work with patients on the fallout of it, because listeners out there, I'm sure, are thinking, wow, can you imagine for a minute what it's like? We're all men. We're a bit obsessed with our penis, as you said with your talk earlier when you went to the Louvre, and we definitely are somewhat obsessed with that. And now suddenly you're curving up, down, to the right, left, whatever way. Think about already how self-conscious most men and most people are normally, and then now you have this curvature, and I find patients are just really upset and really devastated by these issues. Do you find that in your practice as well?
Yeah, no, I was very surprised. And I think most physicians who don't have experience in this area are surprised at it, and they tend to undervalue the amount of impact it has. A lot would say, well, why are they bothered by that? Like, why wouldn't you be more bothered by a tumor or whatever the case? But when you actually see and treat men who are suffering from this, it's very, very surprising on how much of an impact it has. And who knows um, why there's such a link between the psyche and the penis, but there is. And I would say just sexual function in general. Maybe it's a survival benefit, who knows, but there's clearly a very strong correlation. And until you start seeing the patients, you don't realize how much depression, anxiety, suicide, all of these things, it's severe. I mean, this isn't just a minor condition by any means. So
It's so true. And one of the patients was saying to me, they said they had gone to their doctor because after their prostate surgery, they were upset about the different things, including the loss of penile length that they were experiencing and upset about. And they said they were depressed. And the doctor was like, this surgeon had done a lot of surgery. And he was like, well, I really haven't heard that from a lot of patients. And this patient, who was a mutual patient of ours, was like, I can't believe that, because it is something that can be really upsetting, that the fallout from prostate cancer surgery with, the erectile dysfunction, some of the length issues, so many different things that can be difficult to navigate. And in fact, he decided to do a talk for some healthcare providers, and he very wonderfully articulated his suicidal ideation after all this had happened and how upset he really was. And I was like, okay, I know people are going to get it after what he just said, because he spoke very frankly about it. And he said, it's upsetting because you like to think your life's not that caught up in your in sex and intimacy, but when you don't have it and you're really struggling, it can be really, really upsetting.
Yeah, nope, I completely agree. And it's interesting because I had a patient, who's a surgeon, and he was the same way. He said, I used to write this off left and right. People would come, and talk to him about it. And then when he himself got it, he realized, okay, now I finally understand the depth of it. And it's tricky too, because patients don't, come into the office and say, hey, I'm going to talk about the penis today. A lot of times when they mention it, it's already real difficult for them to bring it up. And so they're wanting, someone who's comfortable to talk about it, and then to be written off right away. I think it's a big reason why a lot of us don't end up seeing these men until they're like a year and a half in, because they've been written off, 2, 3 times. And finally they get up enough to say, that's it, I'm going and I'm going to start researching this and get, looking at it. But, but how do you train the world, and how do you, it's just one of those things that I don't know if it'll ever improve that much as far as education on the surgeon side. So
it is, but I really think I really appreciate the device that you came up with. That we use it in our practice, and we use it along with the Xylovex. We do all those kinds of things, but I think it can really be something for men that makes them feel like they're able to do something to help themselves. And you and I both know sometimes even you'll see, well, we can measure the length, we can do all these measurements, which are so important, but ultimately, does the patient feel better? Are they happier with what's going on? Nothing compares to that. And I think sometimes just using the stretching device, using it on a regular basis, feeling like you're doing something to help yourself and seeing some results in combination has a huge impact on these patients, definitely.
yeah, I think people don't like bad side effects. And, a lot of times you can say, hey, I got a cure for the curve, but here's going to be your list of side effects, and people will tend to want to stay real conservative. So one nice thing on the stretching side is there's really not risks with it. It's not a dangerous therapy or anything. And lengthwise, there's not a lot of good options for length. Outside of the stretching device, you jump real quickly to super aggressive things that have the risk of loss of the head of the penis and other things. So there's not a ton of alternatives, in that space for it as is. And I agree that people are bought into this. They're willing to do therapy. They're willing to do whatever it takes on their side. They just want something that's not a gimmick. That's, something that's just going to waste their time and money. They want something that's going to actually make a difference. So
I think too, the practicality of what you created, because some of the devices, you probably remember the older devices, and probably part of why you created this one, you'd wear it for hours during the day, which how practical is that for these men? A lot of these men are working, they're living their lives, and they can't really do that kind of thing. Whereas your protocol, it's not like that. I think it's a very doable protocol for these men, which I think is a really smart thing too.
yeah, I didn't put the slides in there, but I had no intention of inventing anything or anything along those lines. And at Mayo owns you, so it's Mayo's property and everything like that. But what happened was they had me as the on the traction guideline for the ICSM back in 2014, I think. And so I looked up all the data, and we pulled all our data at Mayo of all the guys, and we were the same because the device is recommended 9 hours a day. So we'd tell all these patients, hey, you got to use this device, a different device, 9 hours a day for 6 months. And we track their data. So we'd follow them up, we'd do measurements, all that stuff. I finally pulled all the data from, I forget the number, but something like 50 or 60 patients who'd been trying to do this, and there was no improvement. And I felt horrible I've got these guys 9 hours a day for 6 months using these devices, and there was zero benefit. And so that's when I realized, okay, so I bought a bunch of them, And we tested them out and checked, and I was like, oh, these are just gimmicky. And so then that's when I met with the engineers at Mayo and said, you guys need to build this, and just built it out of Legos and said, build that. And they did. And then we did a bunch of studies on it to see, does it work or not? And sure enough, it does. And so yeah, now it's down to 30 minutes a day, which is a more reasonable therapy compared to the 9 hours,
I couldn't believe it's. I think it's unbelievable because as we moved along, it would get less and less from the 9 hours, but still, who can do 9 hours a day? It's just it's not really at all accomplishable for our patients. So I really appreciate that it's 30 minutes now, and I think that makes a really big difference. And I think a lot of men out there, listeners, are probably thinking, how many men walk into our offices and they'll say to you, yeah. And the other thing is I'm not really very large. And then I try to show them, I say, all right, let's check your stretch length. Let me show you, you are an average size. You are okay. But I think most of the men we see and most of the men in the world think they're small. The average is small. But I try to help them understand and show them with empirical data showing them, look, you're normal. This is what normal is. Now look at you. You're normal. But still, they feel that length loss, especially I think some of those men who've gone through a procedure or surgery or erectile dysfunction and are really experiencing that length loss. So as you said, I think it's really important for us to hear and acknowledge that and know that it's completely real, absolutely for them, but also help them know a little more realistically, you and I are looking at penises and genitals all day long, and they don't know, what necessarily a normal is. So I like to kind of normalize things for my patients, as well as just really acknowledging their pain and their struggle. There's a lot of power in just listening and letting them tell their story and acknowledging it.
Yeah. Yeah, it's funny because if anything, guys tend to be accused of being the opposite, where like I'm 5'7", but I feel 6. And, I can, bench probably 100 pounds, but I feel like I could do 300, and I can probably jump, you go through this thing. But then when it comes to the penis, they're exact opposite. And you can have guys that come in and they're 98th percentile for length. And they're like, I'm way shorter than I was. I'm way, and so it's just funny how it's the complete opposite when it comes to penis compared to everything else. And you do see it. And there's clearly like the pathological group that is, akin to body dysmorphic disorder. We call it penile dysmorphophobia. But there's that group. But then there's the far majority of guys, either one, I was much longer previously, or two, I feel like I'm smaller than average, just like you're saying. And so because it's not one of those things where, if you go to a gym and you start looking at everybody, you're gonna be out of that gym pretty quick. And so it's not, you don't get that direct comparison like other measurable aspects.
No, I think that's so important. And like you said, you'll see these men, I'll say, well, I'm going to show you on the ruler the average size, and then I'm going to check your stretch length. Look, you're a ways beyond that. And they're like, oh, no way that's more than that. And they just don't really sense it.
Yeah, they won't believe you. Yeah.
It's funny, but we hear it and see it every day. Okay, I got a couple questions for you from our audience members.
Please, yeah.
The first one is, as I'm early in the course of Peyronie's disease, what should I be doing now to prevent worsening curvature or length loss? And what should I avoid?
Oh, we get this all the time. And I wish that there were a way that we could somehow coordinate every man who just starts getting the disease in the first month. Let's start a study on it, because the problem is most of us who do a lot of Peyronie's disease, we don't see these men until they're like a year and a half. So I say all that background just because the evidence, strong evidence of here's what you absolutely should do, just is not there, because none of us who do research in this area see men early enough to give a good answer. Now, if you say, well, give me the best available evidence. So no, it's all bad, but what's best available? Best available would say things like NSAIDs, so ibuprofen, anti-inflammatory drugs, probably make very good sense, especially if you're catching it in the first month. PDE5 inhibitors, Viagra, Cialis, there's several studies now showing there's probably benefit in doing that early. That probably is providing internal traction, so you get stronger erections while you sleep, stronger erections when you're not sleeping. That stretches it out. And then traction devices. There's a good study by Martina Salamanca's group out of Spain that showed traction early within the first 3 months will prevent it from getting as bad as it would otherwise. Just like you break your arm, you're going to cast it. You're going to try to prevent it from contracting and having issues. So those are probably the three that have the best available evidence. There was something on interferon. It's a drug that you really can't get easily anymore, but that may have had some role. And me personally, there's a whole group of drugs called DMARDs, which are these disease-modifying anti-rheumatic drugs. I would be willing to bet anything that those would also prevent the disease from getting much worse, but they have a lot of side effects, and so without good data and in a study, it's hard to recommend prescribing them, without at least patients being fully warned about them.
Hmm. I think too, another thing when you ask what to avoid, you want to be a little careful with aggressive sex, especially if your penis is going to bend in the wrong way. And this isn't always the way this happens, this trauma. Sometimes it happens slowly over time with slight traumas. But one of the most common ways is sometimes if you have a female partner, someone on top, and you're being very aggressive and it bends wrong or pops. So being a little bit careful about the way you're having sex so that you don't worsen trauma to that penis that's already had some trauma and curvature and length changes potentially is another thing to think about. Just still have fun, enjoy sex fully, but maybe not quite as aggressive, and be careful, especially if you're not fully rigid and bending the wrong ways or something like that. Avoid those positions or things that would make you do that.
Yeah, and Jeff, just to build on that too, because you're exactly right. One of the most common questions people get or people ask is, should I stop? Do I need to stop having intercourse or anything? And I usually tell them, I say, if you did a survey of 100 sex med experts, I would bet more than 95 would say no. But just like you said, lubrication, make sure the erection's as firm as it can be so it's not buckling or folding. Avoid repetitive minor trauma. A lot of times it doesn't even have to be big trauma, but if it's repetitive to the same area, like constriction bands, for example, things like that, a lot of times you'll see narrowing that starts to occur in men who are predisposed to Peyronie's. So, yeah.
Yeah, I think that's great. Good question and good answers. All right, second question. There's a lot of information online about traction devices, injections, shockwave therapy, and surgery. We get this in our offices all the time. How can I realistically decide what's evidence-based versus what's more hype than help? I love this question because you and I know we hear these questions in our office every single day about all this stuff.
When it's getting harder and harder to differentiate to what's legitimate science versus not legitimate science. And because we'll take shockwave, that's a good punching bag as an example, but there'll be a center that says, oh, these studies showed blah, 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 blah. And they're correct, but that's not giving you in legal terms, they say the truth, the whole truth, and nothing but the truth. So, they may be hitting that first one, but they're not hitting 2 and 3 there, where they're telling you the whole truth and nothing but the truth. So unless you have access to these scientific journals and you're pretty well versed in scientific literature, it's really tough to figure out the answers on your own. You really have to go to unbiased sources that are legitimate sources and what their statements are. So you highlighted at the outset of the program, but the SMSNA is probably the most legitimate sexual medicine source really in the world.
Yes.
And you always want to look to them of what are their position statements saying on things. And so they have a position. In fact, we're just updating it. Probably in the next 6 months, it'll come out as far as shockwave, PRP, stem cells, what kind of effects those have. We just put out a cosmetic surgery one. And so those places are going to be your best bet. Now, in the absence of that, then you look for legitimate names, randomized controlled trials, and you and I see this all the time, but people will put out a randomized controlled trial that's just baloney and, absolutely not true. And so you look at, do the studies repeatedly show the same thing, or are there contradictory studies? So if we have one that shows this, but then a different group shows something completely different, that's a red flag. And on the insider baseball side, we, like you and I, know who are the trustworthy, legitimate sources, and they're not always the ones you'd think, and the ones who are not. And so it is tough to get answers sometimes, though.
It is. And, the other thing is it's like you look at our credentials. We're both board certified in urology. That's the kind of people you want to talk to pull apart the science if you have those questions. And that's why people come to our offices and ask us the questions. But here's the other thing. Just so you understand, just an example like with the shockwave of how you may not be getting the full picture. They're not going to tell you that it mostly works on men with mild to moderate erectile dysfunction, not the men who are walking in our offices who've already tried and failed PD5s and different things. Although, and there is some utility for shockwave, of course, and it's exciting to have a new, totally different therapy, but so far, the research looks to me like it's going to be more of an adjunct therapy than a monotherapy, one that works just on its own. So pulling all that apart. And then you don't even know that the place you're going isn't using the same shockwave type equipment that is essential that was used in the studies that really worked. They're using something completely different, maybe, than what was used in the studies. So it's really difficult to decipher and pull all that apart for yourself, but it's really important because that's what we see happening in a lot of these clinics. They're using a totally different shockwave that's never been tested for these purposes or hasn't been shown to help, or they're using on a patient who study after study has shown it's not going to help that man who has failed PD-5 inhibitors, has failed some of these different things. So that's why, listeners, we're trying to tell you, you got to be a little careful, and it can be really helpful to meet with your own healthcare provider, urology advanced practice provider, physician assistant, advanced practice nurse, urologist, any of those people, especially those certified in urology. SMSNA is a great place to find those people too.
Yeah, and you can usually trace it with money too. Like if you take money out of the equation, then you get the real answer as to what people think is effective and not effective. And so when you take something like shockwave, you look at the centers where the physician, the recommending people don't get any kickbacks, and they don't recommend it. I mean, they'll maybe, if the patient really pushes for it and they have it, they'll say, fine, no problem. But they're not going to come out and say, you should do this therapy. On the flip side, you take someone who gets $8,000 every time they sign someone up for it, they're going to recommend it. And so there's a lot of laws out there that have tried to prevent this over the decades and decades, and you'll never be able to fully control for it. But that's also a good way to get an idea. If you're seeing physician after physician recommending some therapy, traction, something like that, but they're not getting any kickbacks on it, then that's different. If you see someone like me who has ownership in Pathright, who's mentioning that person's biased. Like you can listen, but just understand that person's biased. But Shockwave's a good one of those because you don't see centers that aren't making money on it recommending it generally.
Yes, definitely true. And by the way, just so you know, listeners, I am not biased. I don't work for Pathright or anything else, but I do use the device, and I think it's pretty revolutionary and wonderful for the right person, like everything else. So working with your own provider to determine if it's right for you is what you want to do. But there's a lot of great things out there, definitely. And we don't want to necessarily poo-poo some of these things, even Shockwave for sure, because I think it will have some utility down the road, potentially for maybe adjunct therapy or something else. But anyway, wow, it's been such a great discussion. We've covered so many good points, and I really appreciate all the things you brought forth. I'm going to do a quick closing exercise now and then talk about what's coming up, and then I'll bring you back in to close out the episode. So, as we always do, it is that time, listeners, in the podcast where we are going to talk about and do our closing centering exercise. This one is about reclaiming wholeness, because you are whole. You truly are. As we close today's episode, I just invite you to take a brief moment, whether you're driving, sitting, or lying down, wherever you are, if you can, reconnect with yourself, your magnificent body. Begin by taking a slow, deep breath in through your nose and gently exhale through your mouth. Continue that breathing pattern in your nose for a couple counts, out your mouth, breathing deeply, exhaling slowly. As you exhale, let your shoulders drop. Let your jaw soften. We hold so much tension. Let it go, let it go. Bring your attention to your body as you continue to breathe deeply. Your body, not as something broken or failed, but as something that has adapted, because it has, that has endured, that has carried you through challenges. Silently remind yourself as you deep breathe, I am more than any one part of my body. I am more than any one part of my body. My worth is not defined by measurements, by curvature, or by performance. My worth is not defined by measurement, curvature, or performance. Healing is possible. and I deserve care, compassion, and support. Healing is possible, and I deserve care, compassion, and support. Take one more slow breath in and release it. So if today's conversation stirred up questions, emotions, or hope, I hope, know that you're not alone and that help exists. Restoring sexual health is not just about your anatomy. It's about reclaiming connection, confidence, and wholeness. Thank you for being here and having the courage to engage in these conversations. I really appreciate that. Vic, tell us what's up next week. I know we have an exciting episode next week. What are we going to be talking about?
A year of sex and intimacy. Celebrating the best conversations yet. It's been a year of honest, evidence-based conversations about sex, intimacy, and connection. In the special anniversary episode, Dr. Jeff Albaugh, Vic Sinise, and Dr. Susan Kellogg Spath look back at the most powerful moments and insights from Dr. Jeff talks about sex and intimacy. From navigating desire and pleasure to overcoming challenges like pain, erectile dysfunction, and sexual anxiety, we revisit the stories and science that have helped listeners reclaim their confidence and joy. Join us as we celebrate a year of learning, laughter, and real talk about what it means to be intimate, authentic, and fully alive. Join us on January 6th at 7 p.m. Central Time to learn more.
And you just, I don't know how you come up with these videos, but they're awesome. And it's going to be an exciting episode. So, wow, Vic, it's been a heck of a year, and you really rock it with some of this behind the scenes stuff you do. And I'm excited to have you on the camera next time to talk more. But today, Dr. Trost, gosh, you have contributed so much to our field through Sexual Medicine Society of North America, through your research, through your practice, through so many things that you do. It's been such a pleasure to know you and work with you. And I know you have a wonderful family, so I can't thank you enough for taking time away from all that to share with our listeners today. Is there any final thing you'd like to say before we finish out the episode to listeners?
No, yeah, thank you very much. It's certainly my pleasure. But yeah, I think the key take home is, like you mentioned, hope is there for it. So any treatment, any disease, things like that, the key is just not to forget about it and to think, oh, this is something I'll never be able to address or deal with. There are specialists who are able to address these areas and be able to improve things. It may not get back to how it was before, but that's just kind of life, and life adapts and it changes and it improves. But there are ways that we can certainly improve things and get people functional and in particular regain that confidence and self-esteem. So.
Excellent. And so true. At 63, I can tell you that nothing's like it used to be. And I always say in our clinics, when people walk in, what they really want from us, Dr. Trost, we can't really give them. They want the slightest thought, and there's their erection, and it's straight, and it's large, it's doing everything they want. They want to be 20 with a fabulous erection again. And so I always say, gosh, I feel like I disappoint most of the people who come in with what I'm able to deliver, but we work with what we have. And as you said, I think it's so important for our listeners to remember life's going to change. And as you get older, it's going to change. It can still be wonderful and fabulous, but it ain't going to be the same. But the great hope is that there are things that can help with some of the things that are really upsetting and troubling you, like penile curvature. So don't give up, listeners. My hope and prayer for you is that you have more love in your life, that your relationships are full and meaningful. God knows I've been blessed with that in my marriage and my life. And we thank you for tuning in. Have a great one.
Who's Dr. Jeff talks about sex and intimacy, breaking down the science, setting your spirit free with stories, wisdom, laughter and care, connection and confidence. He'll take